अस्सलाम वालेकुम एवरीवन, वेलकम बैक टू माय यूट्यूब चैनल। आज की वीडियो में बात करेंगे ARF ड्यू टू इंट्रिंसिक रीनल डिजीज, एक्यूट रीनल फेलियर ड्यू टू इंट्रिंसिक रीनल डिजीज डेट में रिजल्ट फ्रॉम ATN एक्यूट ट्यूबुलर नेक्रोसिस डेट में इस्कीमिक और नेफ्रोटॉक्सिक। देन हमारे पास एक्यूट इंटेस्टाइनल नेफ्राइटिस और वस्कुलर कॉजेज भी आ जाते हैं। Acute tubular necrosis, this is the most common cause of the renal failure and is characterized by acute tubular cell damage. Tubular cells have the capacity to regenerate and therefore return to near normal if the patient can kept alive during regeneration phase. Types of acute tubular necrosis are ischemic and nephrotoxic. The pattern of acute renal necrosis is caused by prolonged ischemic due to hypoperfusion causes or same as it pre-renal failure. Nephrotoxic type, this type of acute tubular necrosis is caused by secondary other poisons such as drug, endogenous toxin, exogenous toxin. Renal causes of renal failure are given below. Intrinsic disease of the kidney can cause acute renal failure divided into tubular, intestinal or vascular disease. First is primary, secondary, diabetic neuropathy, amyloidosis, etc. And second one is ischemic and nephrotoxic. Exogenous toxin or contrast agent, heavy metal, chemical, etc. Endogenous toxin are hemoglobin, multiple myeloma and uric acid. Acute interstitial nephritis, usually drug-induced. Vascular polyarterinodosa or thyromo-kidney. Functional AC inhibitors and NSAID. Clinical course of acute renal failure. The clinical course of acute renal failure is relatively short, lasting approximately 10 to 15 days, during which time the individual progress through three phases of pathological process: pre-oliguric phase, oliguric phase, diuretic phase, as well as last one is recovery phase. Pre-oliguric phase, it is the period from the occurrence of precipitating event until the beginning of oliguria. Symptom of primary cause or dominant. Ratio of urea in urine that in plasma become low, 14:1. Normal ratio of 20:1. Rapid reversibility if circulation is stored early and completely. Diuretic phase, the phase is characterized by increase in the urinary output of about 3 to 5 liter daily, and this progressed polyuria and dehydration. Diuresis develops because managed tubular epithelium is replaced by epithelium which has not yet developed concentrating activity. Recovery phase, from the stabilization of the serum laboratory values until the patient attains either total normal or optimal renal function. Diagnosis of acute renal failure. Diagnosis of ARF due to the pre-renal cause, history and clinical examination. With the pre-renal failure, urine output should increase with the volume replacement. Blood transfusion is hemorrhagic shock or normal saline if depletion is due to vomiting, diarrhea or polyuria. Diagnosis, early renal due to ATN may reversible. Incipient ATN if the kidney are subjected powerful diuretic stimulus such as diuretic combination of 20% mannitol 100 ml IV over 5 to 10 minutes followed by pressavomide 120 mg. Satisfactory response is between 10 to 40 milliliter per hour. The diuretic stimulus may be repeated once after 2 hours. There is no increase in urine output. This procedure should not be repeated a third time. If the measurement do not induce diuresis, the diagnosis of pre-renal ischemia or incipient ATN has been excluded. The differential diagnosis then lies between intrinsic renal disease और obstructive neuropathy. अगर यहाँ तक कोई भी बात समझ ना आई हो तो पूछ लीजिएगा। तब तक के लिए इजाज़त चाहूँगी। अल्लाह हाफिज़।